Hi, everybody. Welcome. Thank you for joining me as we discuss practical and clinically applicable strategies for comprehensive neurotransmitter testing and optimization. So let's start with a definition so we're all on the same page. What are neurotransmitters? They are chemical messengers that regulate both emotional and physical processes. So we're talking about things like movement, the stress response, pain, cognition. They tend to function in the CNS. That's generally what we think about in terms of like mental health issues, but they also function in the periphery and they facilitate communication between the brain and the body's glands, organs, and muscles. Neurotransmitters are usually considered that chemical messenger between neurons, but they are located elsewhere in the body too. So for instance, when serotonin is secreted in the gut, we still refer to it as a neurotransmitter. So sometimes people ask me what types of symptoms would lead me to run a neurotransmitter test, and I've listed some of them here. As I mentioned, often these are considered sort of mental health symptoms, issues with cognition, mood, sleep problems, addictions, compulsions, that sort of thing. But there can also be some physical symptoms, pain, headaches, IBS, movement disorders. I would say there are 4 symptoms that will always lead me towards a neurotransmitter test, and that's issues with mood, issues with energy and fatigue, insomnia, and issues with focus and attention. Antidepressants are often the only intervention that's offered for anxiety and depression when someone seeks help in the conventional world. A survey between the years 2015 and 2018 found that antidepressant use increased with age, and it was twice as common among females as males. 1/4 of all the people who took antidepressants in the previous month of this study reported having taken them for 10 years or more. But despite these drugs being commonly prescribed, a study from 2008 found that paroxetine, fluoxetine, and venlafaxine worked no better than placebo. A meta-analysis in 2011 reported that the relapse rate among depressed patients given antidepressants was from 42 to 57%, while the relapse rate for those given a placebo was only 25%. So, as one researcher says, there seems little reason to prescribe antidepressant medications to any but the most severely depressed patients unless alternative treatments have failed to provide a benefit. So what I want to do today is talk about some of those alternative approaches. So I like to think that we're trying to treat the root cause because neuroendocrine imbalances often underlie symptoms. So today we'll be focusing on neurotransmitters, but because neurotransmitter balance and adrenal health are intertwined, we'll be discussing the HPA axis a little bit. We won't be getting into the sex hormone involvement today. But as you know, in other months, we do dive deeply into that component of health. So a common question, or perhaps I should say a common criticism of neurotransmitter testing is that it doesn't measure brain levels. I screen for neurotransmitter imbalance with urinary testing. This has been commercially available in the United States for about 20 years, but it still is a new tool to a lot of practitioners. But when we think about only trying to test neurotransmitters that are secreted in the CNS, I think that we are limiting our clinical approach. We know that neurotransmitters are the autonomic nervous system's messengers that transmit messages between neurons or from neurons to muscles. But these neurotransmitters are secreted both in the CNS and the peripheral nervous systems. And the enzymes that catalyze them are the same, whether we're talking about the brain or the periphery. We definitely are not able to measure what's in the synapse, but urine testing will reflect whole body production, and it does correlate well with symptoms. So if we think about neurotransmitters being secreted in the periphery as well, we know that most serotonin is secreted outside the CNS. Epinephrine and norepinephrine are secreted outside the CNS as part of the stress response. You know, there's dopamine receptors, glutamate receptors, and all sorts of organs. So The only way we would be able to test CNS levels in isolation would be via cerebrospinal fluid. Of course, this would be a very invasive and painful test. So the urinary neurotransmitter test is a peripheral test, just like all of the others that we have available to us, right? If we're looking in serum or we're looking in saliva, that's a peripheral test. We also, I think I have all seen that if we use a treatment that can change a peripheral marker, something like a thyroid or a glucose or a hormone, we'll often see changes in the CNS. So symptoms like mood, cognition, fatigue can be influenced by neurotransmitters both in the CNS and the periphery. So I believe, and have had great success with neurotransmitter testing. I think it provides a good general guide to treatment. It correlates strongly with symptoms, and we can see changes once we've implemented therapeutic options. So here's some more articles to read if you do want to kind of dive into that validity question. Okay, we're going to start this lecture with an overview of some general treatment concepts while our minds are still fresh, and then I'll speak about how to address specific neurotransmitter imbalances. What's nice about these general treatment concepts is that a lot of these can be implemented while you're waiting for the neurotransmitter results to come back to you. So you're going to want to be familiar with this neurotransmitter pathways chart. This visually lays out the pathways, the conversion steps. It helps you understand how the neurotransmitters are synthesized. And so it can help you better think through potential treatments when imbalances are discovered. So we're going to return to this pathway again and again throughout this presentation. After evaluating neurotransmitter levels, we can target the imbalances with the specific precursors and nutrients that are needed. So usually we're thinking about amino acids, cofactors like vitamins and minerals, and then botanical therapies. Generally, we're thinking about nervines and adaptogens. So these amino acid precursors can support low or suboptimal neurotransmitter levels. So generally, I would say wait until you see the neurotransmitter report results before you start implementing any of these. Generally, it's recommended to take these on an empty stomach. So I think of that as about 30 minutes before or 2 hours after eating in order to get ideal absorption. Most of these peptides and amino acids can freely cross the blood-brain barrier. So whereas neurotransmitters are often too big molecularly to get across. So we think about giving these precursors to fuel these neurotransmitter pathways. So for example, we might think about tryptophan or 5-HTP, which can convert to serotonin. Tyrosine can convert to dopamine, et cetera, et cetera. Now, the adaptogens can be utilized. We typically think of them as optimizing HPA axis function, but they do also contribute to neurotransmitter balance because these herbs can help the body in resisting and adapting to stress. So to officially be called an adaptogen, the herb has to enhance physiology without causing any adverse effects or side effects. They tend to promote optimal hormone and catecholamine levels, whether they're too low or too high. So they sort of have a normalizing or a modulating effect. I've listed some of my favorites here, but you may have your own favorites. And then when we think about nervines, these can be given in the morning or at night to restore and balance the nervous system. So I generally think about these for stress, anxiety, insomnia, and even mild depression. Okay, I want to, if you're not familiar with the herb Mucuna pruriens, this is an Ayurvedic herb. It's been used to treat Parkinson's in India for centuries. It contains L-Dopa, also known as levodopa, which is a precursor to dopamine, and so it can support low catecholamine secretion. St. John's wort is an herb that has been shown in studies to provide equivalent relief of mild to moderate depression in comparison to SSRIs. So it can be considered a short-term treatment option for mild depression. I do want to remind you that to use St. John's wort with caution because it's metabolized via some common cytochrome pathways. So it can interact with some common medications. Oral contraceptives is one of them. All right, let's move on to L-theanine. This is an amino acid you're going to want to be familiar with. L-theanine is found almost exclusively in the tea plant, and it is modulatory in nature. So that means we can use it to treat both high and low neurotransmitters. So when you see some of our support guides with treatment, you'll see theanine come up again and again. So it has many functions. It can act as a GABA agonist, which means it's neuroinhibitory and parasympathetic. It can counterbalance the excitability of glutamate, and it can modulate the secretion of neurotransmitters like serotonin, GABA, and the catecholamines. So typical doses range from about 100 to 500 milligrams twice a day. L-theanine has a shorter half-life, so we generally recommend giving it twice a day. Now, some people ask, well, can my patient just drink green tea? Absolutely, but a cup of green tea typically is going to contain between 10 and 50 milligrams of L-theanine, depending on the grade of tea. And so getting a therapeutic dose of L-theanine from tea is generally not very easy to do. We know that L-theanine boosts alpha waves in the brain, which indicates relaxation, and it can modulate mood, create a sense of well-being, and improve cognition. So meditation is always a nice prescription to give our patients. There have been a number of studies evaluating the effect of regular meditation on neurotransmitter levels. So researchers have found higher serotonin levels and lower norepinephrine levels when people who meditate are tested in comparison to people who don't meditate. Meditation can also increase GABA, and we also know that higher melatonin levels are seen the night following meditation. Okay, if we think back to that biochemical pathway, cofactors are denoted in orange. So these are essential to an enzyme's activity. They're sort of the fuel that makes the enzyme function. And clinically, they become important when conversion is slow. So I took this little snippet as an example. So in this example, we're looking at norepinephrine converting into epinephrine. If we had a test that showed that norepinephrine was elevated, but epinephrine was low, it might be an issue with the function of the PNMT enzyme. The cofactors that support this enzyme's activity are SAMe and cortisol. So in addition to giving SAMe, HPA axis treatment might fit in very nicely here to support normal norepinephrine and epinephrine levels. So back to our pathway chart here, again, we know that the cofactors are in orange. So these are typically minerals or vitamins. And in the neurotransmitter biochemistry, it's B vitamins in particular that are really beneficial. I generally keep this pathway on hand when I'm talking to patients about the imbalances we see and why we're choosing different therapies, because I think it can be really helpful to visualize it, because it's kind of a cumbersome concept unless someone is intimately familiar with biochemistry. So a pearl, when we think about cofactors, it can be really helpful to use the activated forms of these cofactors so that the body has one less step to utilize them. So, for vitamin B6, we'd be thinking about pyridoxal 5-phosphate. For folate and B12, we want the methylated forms, that sort of thing. And speaking of methylation, it will be a very important part of your treatment plan, whether you're just considering its effects or actually having to support your patient. So methyl tetrahydrofolate reductase is the name of both the gene and the enzyme that play an essential role in processing folate. Methylation affects a diverse variety of metabolic processes, and when these are interrupted, they can disrupt neurotransmitter creation and metabolism. So this is in two main areas. This is the rate limiting step in the conversion of tryptophan to 5-HTP, and you see this here, BH4. So this is methyl dependent. So 5-MTHF combines with biopterin to form tetrahydrobiopterin, and that is, again, an important cofactor in this conversion. So if your patient has issues with methylation, this will be sluggish, often resulting in lower neurotransmitter secretion. And then additional antidepressant activity is due to the way that methylation is involved in transforming homocysteine to methionine, which then converts to SAMe, which is donating methyl groups to so many of these pathways. So some people like to test for SNPs. Some people choose to treat empirically. Here's some supplements that could be considered. I think we're probably all familiar with these. So when we think about the neurotransmitters that require methylation, people often say it's the monoamines. And for a while, I found that confusing because I thought of serotonin as a monoamine and then dopamine, norepinephrine, and epinephrine as catecholamines. They're actually all monoamines, and then there's a subgroup called the catecholamines. So if you ever see that methylation is associated with monoamine secretion, this is what we're talking about. Serotonin, dopamine, norepinephrine, and epinephrine. Glycine is also methyl dependent. So if you see that these levels are low or suboptimal, you would likely consider an MTHFR issue. Now remember, people who have MTHFR defects still have some functionality of the methyl-supported enzymes. And so the degree to which you'll see low levels of monoamines will vary case by case. And I do want to point out here, the reason epinephrine is in italics is because I have seen patients who have previously identified methyl SNPs and low serotonin, dopamine, and norepinephrine, but the epinephrine continued to be upper range or elevated. I think this is likely due to the importance of epinephrine to the stress response. So all of the available methylation is being utilized to drive more epinephrine production because the body needs it for the stress response. So just a reminder that these patients will typically not show no methylation. It can just be compromised. Vitamin D is another important cofactor. It activates gene expression of both the tryptophan hydroxylase enzyme and the tyrosine hydroxylase enzyme. So these are the rate-limiting steps in the production of serotonin, as we see on the left, and the catecholamines that we see on the right. And then a reminder again, the catecholamines are dopamine, epinephrine, and norepinephrine. Now, fish oil is not a cofactor, but it does benefit the nervous system. So the two major components are EPA, which is an anti-inflammatory agent, and then DHA, which tends to provide fluidity to cell membranes, and it's vital to brain and nervous system function. Inflammation often underlies chronic health issues, and it's been associated with depression specifically. So fish oil can, on its own, have antidepressant effects through its anti-inflammatory activities. All right, let's pivot a little bit and talk about the microbiome. Studies over the last decade have begun to demonstrate a bidirectional relationship between the gut microbiome and brain function. This is called the microbiota gut-brain axis. So this concept suggests that if we modulate the gut microbiome as a strategy for developing therapeutics for complex CNS disorders, we may have some success in treating these. So sometimes people ask me if we're able to predict neurotransmitter imbalance based on the microbiome imbalance that we've identified through testing. And I have not yet seen any data that indicates we could uncover information that specific, but there is evidence that improving the diversity and abundance of the microbiome can improve symptoms of mood disorders and other issues. And then tangential to the specific neurotransmitters that microbes may be secreting, the inflammation that is caused by dysbiosis will just hijack neurotransmitter secretion and metabolism. Chronic inflammation is always the enemy. So whether gut symptoms are caused by dysbiosis or by a pathogen like a candida or a parasite, treating these issues can calm inflammation, which can have a positive influence on neurotransmitter secretion. So when we think about nutritional tools for altering the gut microbiome, of course, changes in diet and increasing fiber is important. Giving prebiotics can be helpful, and then, of course, giving probiotics. And this is a trial that looked at two specific strains of probiotics, a lactobacillus and a bifido species, and they found that these attenuated anxiety and depressive-like behaviors in experimental animal and human models. So evidence suggests that oral probiotics may have beneficial consequences on mood and psychological distress. And the authors proposed three potential mechanisms: the competitive exclusion of deleterious gut pathogens, decreases in pro-inflammatory cytokines, and then communication with the CNS via the vagus nerve. And all of these proposed mechanisms can affect neurotransmitter secretion. So there are ways now to actually determine the makeup of the microbiome with PCR testing. This can be really helpful. So this is a snippet taken from the GI 360 profile that includes assessment of the diversity of the microbiome and also specific details on the levels of pathogens versus beneficial bacteria. So this kind of testing I find can be really beneficial, especially in those cases that are hard to treat. Often you'll find some answers in the gut. And lots of studies listed here if you'd like to dive further into microbiome research. You've heard me mention inflammation. I just want to touch on it with a slide of its own. So not every depressed person is inflamed, but inflammation is a really common avenue to depression. And you really need to consider it when you're trying to determine the etiology of someone's mood concerns. Common factors that can contribute to inflammation are listed here on the left. I think, we're looking at obesity, being sedentary, ACEs in childhood, infection, et cetera, et cetera. They didn't list smoking, poor diet. Those are pretty obvious. We do know that inflammation through multiple mechanisms, so now over here, look at the blue boxes, results in higher glutamate, lower serotonin, dopamine, epinephrine, norepinephrine, and BDNF levels. And all of these things can result in psychiatric conditions, especially depression and anxiety. So this was taken from an article published in 2018 in Psychiatric Times, and they list some helpful considerations for treating mental health, including assessing for a common cause, inflammation. So they recommend considering not using SSRIs as a first-line therapy, and also implementing lifestyle interventions like exercise, sleep hygiene, meditation, etc. All right, so this is a snippet from our Neurobasic profile. So you can see here it's testing for serotonin, dopamine, norepinephrine, epinephrine, GABA, glutamate, glycine, histamine, and phenylethylamine, or PEA. Blue indicates low. This is within the reference interval. So green bordered by yellow, this is technically all within the reference interval, but we do like to show when someone is suboptimal or starting to trend high, because in functional medicine, that can mean something. We want to pay attention to that. And then of course, high levels are represented here in red. If you look at this pattern on the report, based on what we've talked about so far, you can see all of the monoamines are low. Why might this be? Well, we've talked about inflammation and we've talked about MTHFR issues. So now you're already on your way to interpreting these reports from a holistic perspective. And also, while your patient is waiting to get the results back from the neurotransmitter test you had them do, you can get started on some of the general treatment concepts that we talked about, right? Good nutrition, exercise, sleep hygiene, maybe omega-3s, L-theanine, probiotics, vitamin D if they're suboptimal, nervine herbs if they're anxious. Okay, so now we're going to walk through these neurotransmitters one by one to get into some of the nuances. We'll start with serotonin. Biochemically, it's derived from the amino acid tryptophan. And as we've already alluded to, it's primarily secreted outside of the CNS in the gut. The rest of it is secreted in the platelets in the central nervous system. Now, this is by no means an exhaustive list, but listed here are some of the symptoms you might expect to see with imbalanced serotonin. So body temperature changes. Did you know that hot flashes and night sweats are not just due to hormonal changes, they're actually due to serotonin changes as well. Pain, depression, suicidal ideation, racing thoughts, obsessions. So as we move through the types of symptoms you might expect to see with various neurotransmitter imbalances, I'd like for you to try to note how often the same symptoms appear. You're going to see mood concerns associated with many neurotransmitters, cognitive concerns associated with many neurotransmitters. This is why I find testing to be such an important tool. It helps us tease through the nuance of symptoms and really identify what is an issue for a particular patient. Appetite change is common with imbalanced serotonin levels. This could be a lack of interest in eating, but more commonly what we see is cravings for sweets and simple carbs. This is an attempt at self-medication to raise serotonin levels. So if we have low serotonin, we might be driven. We might have cravings for sweet, salty snacks, the donuts, the chips, rather than the apples and the broccoli. When we eat these foods, we might have a temporary increase in serotonin secretion. So this type of eating of these types of salty and sweet carbohydrates is an attempt at self-medication. So what we've learned is that neurotransmitter imbalances can actually drive behavior. Okay, I'm going to show you a treatment slide for every neurotransmitter we're discussing today. So you'll see ways to support the neurotransmitter in question. If it's low on the left, if it's high on the right. So I'm going to talk you through this slide just so we can sort of orient you to what we've done here. And I won't talk through all the other ones that will come up. But you can see here, if serotonin is low on the left, we've listed things to consider. So you might consider tryptophan, which is the ultimate amino acid, but people are often vitamin D deficient or have issues with iron levels or methylation. So sometimes jumping ahead to 5-HTP is a good treatment strategy because then you take out the influence of any of these that could be low. We think about L-theanine, as I mentioned, because it can address both low or high. Rhodiola is listed here, and it's also listed over here. So a quick word about that. Rhodiola in low potencies has been shown to increase low levels of serotonin, and rhodiola at very high potencies can actually suppress it. And you can see here a lot of the cofactors that move these enzymes along. So if someone is iron deficient, if they're vitamin B, D, or methyl deficient, then bringing those in can help to support serotonin secretion. And then if serotonin is high, we think of L-theanine, again, for its modulatory effect, those high-dose, high-potency rhodiola extracts, and then cofactors that help to support metabolism. We'll get into that in more detail as we move forward. A quick word about melatonin, which you see listed here. So melatonin, we know, is tryptophan becomes 5-HTP, which becomes serotonin, which then goes on to make melatonin. But studies now show that it seems to be a bidirectional relationship between serotonin and melatonin. So giving melatonin can actually, in some patients, boost serotonin levels. All right, let's move on to dopamine. Dopamine enhances the reward response, especially if the reward is perceived as greater than expected. So sometimes I use this example. So do you remember when you were a child and maybe there was one of those gumball machines that had the big shiny gumballs in it? And if your mother gave you a quarter, you'd drop it into the machine, turn the crank, and a big shiny red gumball would drop into your hand. And that was really exciting. But did you ever have the experience of putting in the quarter, turning the crank, and having 2 gumballs drop into your hand? That thrill that you feel to have that unexpected second gumball, that little thrill, that's driven by dopamine. That was an unexpected reward. People who are extroverts tend to show higher levels of dopamine activity than people who are introverts. This neurotransmitter stimulates the reward and pleasure centers in the brain, and it also affects movement and behavior. So it allows us to move toward an expected reward. And like I said before, that reward response is enhanced if the reward we receive is greater than expected. This is also one reason why gambling can become addictive, because if we hit it, we get a surge of dopamine, and that feels so good. So dopamine is a catecholamine derived from the amino acid tyrosine, and it converts to the other catecholamines, norepinephrine and epinephrine. Norepinephrine outside of the United States is called noradrenaline, and epinephrine is called adrenaline. And this is in the medical research. So if you're ever reading and you see those two words used, just know that they're interchangeable. So this is how people with excess dopamine may see the world. They may, that feeling of everyone being out to get you. Things that once seemed safe and comfortable no longer do. So some symptoms that you might observe include increased worry, paranoia, ADHD, a decreased ability to interact socially, and a desire for instant gratification. If dopamine is low, we can see things like Parkinson's disease, but also mood swings, depression, anxiety, and a loss of motivation. That lack of motivation, a loss of interest, that's sort of a uniquely dopamine symptom. And then there's some pathological states, schizophrenia, autism, ADHD, and restless leg syndrome that have been associated in the literature with dopamine deficiencies. Now, we talked about low serotonin, causing some people to kind of reach for carbohydrates. When it comes to dopamine, people may be more prone to addiction. So they'll often engage in behaviors that can feel risky. Overeating food, using drugs, gambling, doing things like jumping out of airplanes, whatever the case may be, because that will result in them getting a bit of a dopamine surge. And so because they want that surge again, they'll engage in that activity again. And in some folks, that can lead to a cycle of addiction. That this is really, again, just an attempt to self-medicate. Now, this is interesting. Dopamine is sometimes called the motivation molecule. In this study, lab mice that are dopamine deficient are so apathetic that they were literally starving themselves to death, even when the food was readily available. That's how important dopamine is to motivation. And here you can see strategies for supporting low and high dopamine. Now, what about massage? Not just for the back. Studies suggest they can decrease salivary cortisol if it's elevated and also increase urinary serotonin and dopamine. Okay, now we're going to move downstream from dopamine into those other catecholamines. Dopamine converts to norepinephrine with the addition of a hydroxyl group. So this is where my little chemistry nerding out comes in. And then we add this methyl group to make epinephrine. So they're molecularly similar, and they work together as part of the fight or flight response, right? They affect our heart rate, our blood pressure, and also help to release glucose from energy stores. Norepinephrine is released during stress to stimulate this fight or flight response. Most of the norepinephrine is released in the central nervous system, but some is released in the periphery from the adrenal medulla. In the central nervous system, it's released from this area called the locus coeruleus. And then epinephrine is primarily synthesized outside of the CNS in the adrenal medulla via ACTH. So ACTH stimulates the adrenal cortex to produce cortisol, and this also enhances epinephrine synthesis. So it's utilized in the brain, but its main impact is in the periphery. And just a quick note about the adrenal cortex and medulla here. This is one reason why those adaptogens are utilized for both HPA axis and stress response, epinephrine, norepinephrine, because both of these are secreted, well, all three of these are secreted from the adrenal gland. It's just cortisol is from the cortex, and these catecholamines are from the medulla. So in the periphery, we all know this, norepinephrine and epinephrine work together to coordinate that fight or flight response. They regulate carbohydrate and lipid metabolism. They are released from storage vesicles in the adrenal medulla in response to stress. So not only just like fright, but also exercise or cold or low blood glucose. So they increase the degradation of glycogen and triacylglycerol, as well as increase blood pressure and cardiac output. So we talked about serotonin causing people to sort of go for carbs, low dopamine causing people to engage in behaviors that give them a jolt of dopamine. Well, the same can be said of catecholamines. When people are low in epinephrine or norepinephrine, they often do these crazy adrenaline junkie type things, right? They're intentionally inducing a fight or flight response by engaging in these risky behaviors. So jumping out of an airplane, being on roller skates around a roller coaster. This is a real thing. People do this. This causes that release of epinephrine. It causes a high, which makes these people feel good. Now, I do want to make a quick note here. It's great. when people want to do these exciting things, right? We're not saying there's anything wrong with being an adrenaline junkie, but the question is, when does it interfere with someone's ability to just sort of live a normal life? If people don't feel alive unless they're engaging in these risky type behaviors, this is when we might consider intervening. Okay, because catecholamines are excitatory, when levels of epinephrine and norepinephrine are low, we might see a dampening effect. So poor attention and memory, decreased concentration, brain fog, reduced socialization, a loss of alertness, depression, pain, and then, of course, that lack of interest, lack of arousal, lack of motivation. Conversely, if they're too high, this is too much excitatory activity. So physically, we might see palpitations, tachycardia, arrhythmia, headache, restlessness, etc. And then on the mood side, irritability, agitation, anxiety, sleeplessness, inability to relax, not being able to focus because the mind is racing, essentially being overstimulated. And then here are your slides on supporting norepinephrine and epinephrine. Okay, part of this report is the norepinephrine to epinephrine ratio. So what this does is examine the conversion between norepinephrine to epinephrine. So one of the reasons why this is helpful information is because if the ratio is high, we know that this conversion is not efficient. So you can see here in this example, lots of norepinephrine, not much epinephrine. Something is causing this enzyme to be sluggish. What fuels that enzyme? SAMe and cortisol. So it could suggest that HPA axis testing would be helpful because you want to know if the patient has low cortisol. So I think it's really helpful to have that information along with the catecholamines because it has helped me start to think about stress as being sort of 3 phases or 3 levels. So I just want to walk you through them really quickly because I think knowing where they are in this continuum of the stress response will help you choose the appropriate therapy. So another reason why this is important is because patients can present with the same symptoms. Usually they tell you they're tired, they're moody, that can be depression or anxiety. They have trouble focusing and they have trouble sleeping. But patients experiencing these same symptoms can fall at different places in the stress response. So phase 1 or early stress might look like this, where we see lots of cortisol being secreted. And then the catecholamines are pretty elevated. Both epinephrine and norepinephrine are elevated. At this point, this person is pretty good at responding to stress. All of these physiological processes are appropriately responding to stress. But the sympathetic nervous system is not designed to stay in high stress mode continuously for months and months and months. Then we can start to see a maladaptation or an adaptation in the body, which becomes mal because it negatively affects the way that we're able to interact with the world. Some people call this adrenal fatigue, but the adrenal gland is not really fatiguing. Really what we're seeing is that the sympathetic response and the HPA axis are adapting to this constant onslaught of stressful stimuli. So at this point, we can see the body beginning to adapt. So generally, what seems to be happening is that cortisol levels start dropping. And we can see changes in nervous system secretion. As I mentioned before, in terms of methylation, and the same is true with stress, epinephrine is such an essential part of the stress response that generally it continues to be elevated even when cortisol and norepinephrine start to drop. Eventually, the body can no longer adapt. These patients become very, very depleted. This is what we would call a late stage or a phase 3 HPA axis dysfunction. These guys generally feel pretty crummy. They're pretty exhausted. Now, there are no hard and fast rules governing these changes, but these stages can reflect the dynamic changes that can happen physiologically when patients are exposed to chronic stress. All right, now we're going to move on to glutamate. Glutamate is the most abundant excitatory neurotransmitter in the body. It's molecularly similar to GABA, but the two have opposing neurological effects. And you can see the enzyme GAD, or glutamate decarboxylase, is what turns GABA glutamate into GABA. And it requires vitamins B6 and taurine to help make that happen. So glutamate is excitatory. So pathologies that are associated with high levels are anxiety, insomnia, issues with concentration that could be called ADHD. And then if it's low, because we have too little of the excitatory glutamate, we could see depression, fatigue, brain fog, et cetera, et cetera. If your patients are testing with high glutamate, you're going to want to ask them about their diet. We're probably all familiar with MSG, monosodium glutamate, but there are a lot of ways that glutamate can be hidden in foods. So I wanted to just give you this list. So even if your patients tell you, hey, I'm eating a really clean diet, if anything they're eating contains yeast extract, if it's hydrolyzed or textured, often the case with some of those vegetarian, like fake meats and stuff, or even a gelatin, these are all arguably healthy food choices, but they could contain glutamate. This can be helpful to keep on hand if you're finding high glutamate and you're having trouble explaining why. So how do we support glutamate when it's low or high? Here's some things to consider here. Now, GABA, glutamate is the primary excitatory neurotransmitter. GABA is the primary inhibitory neurotransmitter. So with GABA, we're talking about calming effects. I am a little bit of a dork, but I find it fascinating that we've got the most prominent excitatory and the most prominent inhibitory neurotransmitter, and they're just one enzymatic conversion apart. That's such a fine, nuanced detail that the body is managing. It's just amazing to me. So that enzyme, that GAD enzyme, is helping to keep this balance between the two. GABA, because it's inhibitory, some drugs have utilized GABA receptors to promote inhibitory or anti-anxiety effects. So benzodiazepines, muscle relaxants, things like that. So again, GABA is inhibitory. So if it's low, we might see panic anxiety. If it's high, we can see kind of a depression, like a depressed symptom. So actual depression or drowsiness or difficulty concentrating, that sort of thing. Now, I do want to quickly give you this little pearl. GABA levels can become elevated as a compensatory mechanism when excitatory neurotransmitters are high. So if your patient is, for whatever reason, secreting too much excitatory activity, too much epinephrine, dopamine, glutamate, et cetera, the body may try to maintain homeostasis by increasing GABA. So if you see elevated GABA in a picture, something like that, and they're not supplementing with GABA or something that could increase GABA, that's likely the body's attempt to maintain homeostasis. And that would be a positive finding in a case like that. But here's some ideas about supporting low and high GABA. Moving on to histamine. It's also excitatory. It's not only responsible for the allergic response, it is an excitatory neurotransmitter. It's involved in the sleep-wake cycle and the inflammatory response. So it has a sort of a dual role, histamine does. It's a neurotransmitter and it's an immunomodulator. Its precursor is the essential amino acid histidine. I primarily think of histamine as being important in terms of its ability to inhibit sleep. If histamine is present in abundance, it can increase wakefulness, which results in insomnia. So before I was able to utilize this test many, many years ago, I would sometimes have patients come in, and usually it was just women because that's who was often coming in to see me, but they would say, the only thing that helps me sleep is Benadryl. And now I think if I could go back and retest those patients, what we would find is elevated histamine in those. So sometimes that's the way I'll explain histamine's effects to my patients, right? If we think about the side effects of those first generation antihistamines, the Benadryls, they cross the blood-brain barrier. That's why when you take them, you feel drowsy. Some of the newer antihistamines, the Claritin and the Zyrtec, those are designed not to cross the blood-brain barrier, which is generally why they don't have sleepiness as a significant side effect. Low histamine levels are associated with drowsiness, hunger, memory issues, and mood, whereas if it's high, again, you could see the wakefulness, the insomnia, but also some allergy-like symptoms and some gastrointestinal concerns because histamine does have many actions. And here's some ideas of supporting histamine. A quick little note about histamine, because a lot of foods contain histamines, and these are aged foods, smoked foods, fermented foods. If histamine is high in your patients, you might consider avoiding those foods, but also sometimes these foods are kind of important culturally and it's difficult for patients to give them up. So one strategy is to take diamine oxidase with meals because this can specifically help to break down the histamine. Okay, glycine. Glycine is the second most widespread amino acid in the body. It also acts as a neurotransmitter. It's made in the liver, mostly from serine. High concentrations are found in the skin and connective tissue and muscles. In the CNS, it's primarily found in the spinal column. It's inhibitory. I think of it as sort of being the after GABA, it's the most important inhibitory neurotransmitter. It helps to regulate the body's temperature during sleep. So if your patients are overheating, having night sweats, sometimes giving them glycine can help, especially if glycine is low. We know if glycine is too elevated, it can affect cognition and cognitive processing. Glycine, because it's found in so many of those connective tissues, it's something you want to ask about. So if glycine is too high, you want to ask about diet. So are they drinking a lot of bone broth? Are they taking collagen, putting it in their smoothies, that sort of thing? And if it's low, that can be a therapeutic. You can have them make some bone broths and sip them, and that's especially great when it's cold outside. Okay, the last one we'll speak about in the Neurobasic profile is phenethylamine, or PEA. PEA is excitatory, and so low levels are associated with ADHD, depression, and even autism. And if it's too high, we can see anxiety, nervousness, etc. It's excitatory. But PEA is particularly interesting because of its association with cognitive concerns. And in fact, some studies indicate it could be considered to be a biomarker for ADHD. So this is a meta-analysis, and they found that 3 studies confirmed that urinary PEA levels were significantly lower in patients with ADHD, and that these levels normalized with treatment. So they go on to say that PEA levels could be considered a biomarker for the diagnosis of ADHD and also then for evaluating treatment efficacy, because they were giving things like Ritalin and Adderall and seeing changes in PEA. But we see changes in PEA also with therapies like you might see here. Giving the amino acid phenylalanine, giving PEA itself. Now, I do just want to point this out. So this PEA is phenethylamine. It's not the palmitoyl-ethylanilotamine. I know I got that wrong. But that PEA was developed to help with pain management. This PEA, phenethylamine, is important for focus and attention. So that is an important distinction if you're looking for a PEA supplement. And here's some references to support all that supplementation information. So what do we do when we get these results back? So in addition to sort of just treating linearly, this is low, I'm going to give these precursors, this is high, I'm going to try to maybe blunt it. We want to think about excitatory and inhibitory balance. So I've listed here on the left the neurotransmitters that are considered to be excitatory, and on the right here are the ones that are considered to be inhibitory. GABA, glycine, and taurine, which we'll talk about in a second, are definitely inhibitory. Serotonin, I think of more as a, what's the word? It's not excitatory. It's not necessarily inhibitory, but it can create melatonin, which helps us sleep. So kind of a moderate one, but definitely not excitatory. Okay, so if you want a deeper dive into how these neurotransmitters are affecting health, you might want to consider metabolism. So now if we're looking at the same biochemical pathway, we can think about metabolism. So again, a review, we've got the neurotransmitters are purple, the enzymes are blue, the cofactors are orange, and then we've got metabolism here. We're looking at COMT enzymes and MAO enzymes. And so if you want to be able to see how those enzymes are functioning, you might consider the Comprehensive Neurotransmitter Profile. So in addition to the neurotransmitters that we've already talked about, this test also looks at metabolites, key amino acids, and some trace amines. So I do recommend this profile for complex cases. If you know that there is a genetic defect in COMT or MAO, you would probably want to do this test so you could see how those SNPs were actually affecting neurotransmitter levels. If you've got more moderate to severe cases of depression or anxiety, or if it's because you've totally mastered the Neurobasic test and you just kind of want now to get into some of the more meat of things. So again, we're measuring trace amines and some other markers, but the real important information, I think, with this expanded profile is being able to get an idea of how the MAO and COMT enzymes are functioning. So when we think about monoamine oxidase, or MAO, it works by clipping an oxygen off of an amine group. It inactivates monoamine neurotransmitters. It can also break down the monoamines that are ingested in the food that we eat. So there's two subtypes, MAO-B and A. It's really not important to know the difference, but they're written down here for you in case you want to get into that nitty-gritty. There is some interesting research on MAO variants. This is just one example. So this study suggested that there might be a connection between certain variants in a person's response to stress. So people who carried the H allele, meaning that the MAO was faster, had a greater cortisol response to stress compared to those with the L allele. Now, of course, as with any SNP, we want to keep in mind that environment and upbringing and nutritional status and inflammation, all of these will affect enzymes. So having a genetic variant doesn't necessarily determine destiny. It just might indicate that more care needs to be taken with those patients. So I snipped out of that pathway all of the areas where MAO is functioning and important. It might be important to understand when these levels are potentially too high or too low. So if MAO is sluggish, we might see, for instance, an elevated serotonin, but a low 5-HIAA. That's serotonin's metabolite as driven by MAO. An overactive MAO enzyme might manifest as low serotonin and an elevated 5-HIAA. So you can see here, if MAO is sluggish, we want to think about B vitamins, particularly 2 and 3. Iron, if someone is iron deficient, giving them extra iron probably is not going to help that much. And also avoiding things like tobacco and caffeine. If MAO is overactive, that's a lot of oxidation. So bringing in antioxidants can be really helpful. And then there's some inhibitors like St. John's wort. So St. John's wort is the most well-studied, but here's some other natural MAO inhibitors that could be considered. And more research. All right, now catechol O-methyltransferase, or COMT or COMT, this degrades catecholamines, so the dopamine, the epinephrine, and the epinephrine. But it actually also requires MAO for complete metabolism. So what this enzyme does is introduces a methyl group to the catecholamine that's donated by SAM. That means this is a methyl-dependent function. There have been some pharmaceutical COMT inhibitors that have been developed for things like Parkinson's disease, where we're trying to keep more dopamine around for as long as we can. So there have been a lot of COMT variants that have been identified that can either slow or speed up the activity. According to one review, 80% of the population had at least one SNP in this gene. So that's very significant. But remember, having high or low catecholamines doesn't necessarily identify whether someone has a variant. And then having a variant, again, does not guarantee a certain neurotransmitter pattern, but it's just another piece of the puzzle. So when catecholamines are out of range, there's the possibility that a variant is present. It could be a contributing factor. If the COMT is fast, meaning it's metabolizing dopamine, epinephrine, norepinephrine quickly into the metabolites, you might see issues with focus, memory, concentration, low mood, low motivation. And if COMT is slow, we might have too much of those catecholamines. That's when we can see that neuroticism, the paranoia, lower stress resiliency, that sort of thing. And so looking at 3-MT, norepinephrine, and epinephrine will give us insight into the activity of the COMT enzyme. So here's some ideas about ways to support a slower fast enzyme. If it's sluggish, we're generally looking at cofactors, SAMe, magnesium, MTHF, or methyl B12, also some of the cruciferous foods. But if it's overactive, we generally want to support the MAO enzyme. Now, why would we want to do that? Well, because catecholamines are a two-step metabolism, so it requires both COMT and MAO. So it's very common we get this question, why would I run the Neurobasic profile versus the Comprehensive Neurotransmitter Profile? They're both great to evaluate deficiencies or excesses. The Comprehensive Profile just includes more information. So it's really just sort of your comfort level with reading these. If you're just getting started, I recommend starting with the shorter profile. It gives you most of the information you need. But if we want to know about metabolism, the Comprehensive Profile is the one to choose. All right, how do you decide between doing a 24-hour urine collection or spot collection? I've sort of tried to summarize that here. 24 hours is, of course, giving us an average of the neurotransmitter secretion throughout a whole day. It will reflect the influence of foods and stressors. If your patient has kidney disease, it's the only option, but compliance can be a concern. There's one study that indicates up to 40% missed voids with a 24-hour collection, and if you have missed a void, the whole thing is bunk, essentially. You're not going to get good correlation with actual values if you don't know the exact volume of urine in a 24-hour period. And a quick little aside, I have been dealing with some of the cognitive changes that can occur with perimenopause, and I was trying to do a 24-hour collection, and I just could not remember to collect each one. So 24-hour collections are cumbersome, and when our patients come to us stressed and overwhelmed, and sometimes with cognitive concerns, it's a big thing to ask. So the spot testing is generally what I recommend. It is generally a baseline AM collection. So this allows us to get the same type of information that a 24-hour collection would, but it's only one collection. We have less environmental influence. So that first AM means they have not yet eaten, hopefully haven't yet fought with a spouse, had to get the kids out the door. So it's more of a baseline. It doesn't capture, though, the variability that we can see over the course of the day. It correlates well with the 24 hours, and you can do either a first or second void. And here's kind of the differences between those. Second AM void used to be industry standard, so we still offer that, but I think most people have switched to that first AM void because you just wake up in the morning, catch that void, and you're done. Easiest with compliance, and that includes the neurotransmitters that have pooled throughout the night, and that can be especially interesting if people are having some insomnia or hot flashes and night sweats or whatever's happening over the course of the night. Okay, to summarize, I hope this overview has provided a good roadmap to optimizing neurotransmitter secretion and metabolism in your patients. Because patients can present with very similar symptoms of fatigue, mood concerns, issues with focus, concentration, and insomnia, I think it can be really helpful to use this testing because the etiologies of these symptoms are complex and they can be different in each case. I have found that addressing neurotransmitters can make a significant difference in understanding and treating the individual's physiology and the patient in front of you. So thanks so much for your attention. And now I'm happy to take any questions you may have.